This is the fourth installment of our Implementing High Quality Primary Care webinar series. Every Tuesday this month, we've been diving into a different theme of the new National Academies report entitled Implementing High Quality Primary Care, Rebuilding the Foundation of Healthcare. In the previous webinars, we've covered topics such as payment reform, access to primary care, workforce and training needs, and this morning, we're really excited to discuss digital health and how digital health can be optimized to more effectively support and promote the delivery of high quality primary care. I'm really excited this morning to be joined by a fantastic group of committee members and panelists who I'm going to introduce in just one moment. After I introduce them, we're going to have a brief presentation summarizing the very general outline of the report and then the report content that's related to digital health. After that, we'll move to a discussion for the majority of our time together with our panelists before taking questions from the audience for the remainder of the webinar. Just a note that a recording of this event and the slides that we present will be available online after the event concludes. So we're really excited to have you here with us and looking forward to your participation. With that, I want to introduce both the committee members that have joined us as well as the panelists. First, my name is Asaf Bitan. I am the Executive Director of Ariadne Labs, which is a health systems innovation center at the Harvard School of Public Health, as well as Brigham and Women's Hospital, where I'm also a primary care physician practicing in Boston. I am also a senior advisor to CMMI on primary care policy, but none of the views that I express today are in any way expressive of CMMI policy. I would like to introduce Alex Christ, who's Professor of Family Medicine and Population Health at Virginia Commonwealth University, an active primary care clinician and teacher at the Fairfax Family Medicine Residency Program. Also joining us is Brenda Rice-Brennan, the Director of Mental Health Integration at Intermountain Healthcare. She's a medical anthropologist and a psychiatric nurse practitioner who's led Intermountain Healthcare's adoption, diffusion, and evaluation of clinical integration for mental health and primary care. Unfortunately, Lucy Lakem could not join us today. She's another member of the committee who's Executive Associate Chair and Professor at the Department of Internal Medicine at the Dell Medical School of the University of Texas at Austin. We're really pleased to have three panelists together with us today. First, Andy Gettinger served as the Chief Clinical Officer for ONC until April of this year. He is also an emeritus professor of anesthesiology at the Geisel School of Medicine at Dartmouth and adjunct professor of computer science at Dartmouth as well. Sean Cavanaugh is Chief Policy Officer and Chief Commercial Officer of Aledade, a health IT company that partners with primary care physicians to build and lead accountable care organizations. He's previously served as the Deputy Administrator and Director of the Center for Medicare at the Centers for Medicare and Medicaid Services. And finally, Josh Mandel is a physician and software engineer. He serves as the Chief Architect for Microsoft Healthcare, Chief Architect for Smart Health IT, and is a lecturer at the Harvard Medical School Department of Biomedical Informatics. So with that, I think we're going to move into the next phase here, if we can just get the slides up, to really present to you a very brief overview of the report with the deep focus, of course, on our topic today, digital health. So next slide, please. As you can see from this slide, we were really blessed to have a wide-ranging committee, an unusually large committee, given the breadth of the topic about how to implement high-quality primary care. And what I would just really point out is that this was a committee that encompassed a wide variety of professions, of perspectives, medical anthropology, sociology, government experience, payer experience, a range of pediatrics, family medicine, internal medicine, geriatrics, leaders of community health work organizations, leaders of federally qualified community health centers, and more. So it's impossible to, within a small committee, encompass the entire breadth of primary care, but certainly this was a broad committee, and we aimed through many mechanisms to engage a broad set of perspectives. Next slide, please. The statement of task is really important that you understand what the report was and its core foundation. It really builds upon the 1996 Institute of Medicine report on primary care, really the last large major report by what was then the IOM and is now the National Academies on primary care. And the committee was tasked with something very specific and broad, to develop an implementation plan on how to build on the lessons from the report 25 years ago, incorporate what's been learned as primary care has transformed and been studied and gone through many market changes, so that we can understand how to build a primary care of the future, especially for underserved communities, to inform primary care systems and really focus on the implementation steps and actors necessary to improve the service and provision of primary care across the US. Next slide, please. It starts with an updated definition, which I'm not going to read because it's on the slide, but just to highlight that the definition really builds upon the previous IOM definition, but highlights a couple of key areas as we had this task of thinking about the necessary next steps to producing a high quality primary care system for all. That means that we focused on and included in this updated definition whole person and integrated healthcare, and done with and by interprofessional teams with a focus on access and equity. And really that these address the functions and the needs of the majority of an individual's health across their lifespan and across the different settings in which they aim to achieve better health. Next slide, please. I think the other important part as we look at this implementation report, it's very aims to be very practical and also very much in the service of next steps. This was not a report that just, again, documented the well-known evidence for primary care, but rather highlighted that evidence in service of an implementation plan. And one of the findings of the report that sort of cascades throughout it is the idea of primary care as a common social good. The preponderance of evidence plus the necessity of primary care as the backbone of any high-performing equitable health system highlights the need to think of it not just as another component or another feature or another corner of the healthcare marketplace, but rather as a common good that has core common societal value. And yet that value is in contrast to the precarious state that primary care finds itself in terms of its relative underpayment, its workforce challenges, its delivery challenges. And so thinking of primary care in its implementation through the rubric of a common good requires that public policy be needed for common oversight and monitoring and development and acceleration of this common good, and also requires a set of stakeholders and actors for advocacy, organized leadership, and public awareness. So that's just a sort of common foundational element of the report. Next slide, please. We are only going to talk about one part of the report today, but it's really important that a 400+ page report be able to be encapsulated into one slide or 5 tweets. And quite frankly, the recommendations of the committee for implementing high quality primary care really fall in this cascade here around paying for primary care teams that serve people, not doctors, to deliver services, ensuring that high quality primary care is available to everyone, training the primary care team workforce where people live and work. Today, we're going to talk about how to design and redesign information technology that better serves patients, care teams, and families. And finally, ensuring accountability mechanisms for this implementation. So in the next slide, I believe that I'll be handing over to Alex Christ.
Thank you so much, Asaf. That's a wonderful introduction. You always frame it so well. And I really love it when you say it's important to encapsulate a 400-page document into one slide. And you really pushed our group to do that. And I feel really good about those 5 different recommendations. As Asaf mentioned, we're going to delve into digital health. So let's go to the next slide and get started here. So digital health was not covered in the 1996 report on primary care. So this is new content in this NASM type of a report framework. And, if you look across all healthcare providers, not just primary care, digital health can be a major source of professional dissatisfaction and burnout. I haven't met a primary care clinician that isn't happy to complain about their electronic medical record system. It's kind of a common bond that we all experience. Now, on the other hand, I'll go on to say that digital health it's just an essential infrastructure to ensure the success of this report. And I want to build on Asaf's statement about primary care as a common good and actually say we should probably view our digital health infrastructure as a common good as well. And it probably needs those same elements of thinking about common goods as we are asking people to think about in terms of primary care. Can you go to the next slide? One unique question and valid question is to say, well, why is digital health so uniquely important for primary care? It's important for anyone in the healthcare delivery system. What is special about primary care? And I think there are 4 things that relate to this, just that are about the nature of primary care, Barbara Starfield's 4 C's, and they start to show us why digital health is uniquely important for primary care and of utmost importance to do right. So we talk about primary care being the point of first contact. And that means that primary care is also the point of first information seeking on new health issues. We think about primary care as being comprehensive. And that means that digital health for primary care needs to be whole person information applied to any potential situation. Next slide. The other element that we think about with primary care is that it's continuous. It's grounded on this longitudinal relationship over time. And from a digital health standpoint, that means that primary care needs longitudinal records that reflect a person's life story. And this is complicated compared to where we're at right now, where many records are disease-focused and instance-based focused. And then primary care is supposed to coordinate all of care. And what that has meant as we have adopted and implemented digital health across our healthcare system is that we've essentially charged primary care with creating the comprehensive patient record. Primary care has to go out, find all the information, pull it together, enter it into their system, and then they're frequently the entity that shares it with everyone, shares it with specialists and health systems so that when someone goes into the hospital, we know their information and can take care of them. When a specialist is seeing a patient, they know the whole story in the background. But this is a monumental task that we've assigned to primary care. And it's actually really straining primary care from really achieving the person-centered, whole person-focused care that we could think about doing. Next slide. So when we were thinking about digital health, we adopted a very broad definition. So in the chapter, there's a lot of information, and we talk a lot about data and health information, and specifically electronic health records and patient portals. But we are really trying to think about this very broadly. So it's not just those information storage and access tools like EHRs and patient portals. It's ways people access healthcare, like mobile applications or telehealth. It's part of self-management, like mobile applications or remote monitoring, wearable technologies. It's population tools like registries. It's connecting tools like communication systems, and it's tools to try and make the healthcare that we're delivering easier. So analytic systems, population health tools, artificial intelligence, chatbots, all of these types of things are really included in what we're talking about for digital health. Next slide. This slide shows kind of a very simplistic view of how we are thinking about the functions of digital health. But I think these 4 basic functions kind of summarize what we're looking for from digital health. So one element and one thing we need digital health to do is to collect information. So this is from all types of sources. So a doctor entering orders or describing what's happening during an encounter, a diagnostic reporting system, so that actual test that's ordered or done on a patient or image that's generated, that's part of collecting data. Patient reporting systems like wearables or ways people can say how they're feeling or thinking. So that's sort of the first step. The second step is aggregating information. So if you have all these multiple sources collecting information that pertain to a person's health, we need a way to kind of bring this all together, find it, aggregate it, and put it into one place for people to use. The third thing we think about is analysis of information. So analysis becomes particularly important if you're talking about wide ranges of lots of information. And as a family doc, I get really scared about the idea of my patients having, tools like my little Fitbit here and other things that are kind of tracking things continually and sort of thinking about me being responsible for that. We have a real risk of information overload. And so those analytic tools are really important to kind of separate the wheat from the chaff and to show people what's important. And then that last phase is application. And this is gigantic. So this is about how do we actually take all this information and needs and other factors and apply it to staying healthy and to being well. And this could be things that people use individually, that are used by different care team members, that are health system used, that are community used. And it includes not just tools for delivering healthcare, but also about making it easier. So, why shouldn't something listen in on my encounter with the patient, record what's happening, and document everything for me so that I don't have to bother doing any of that work and I can focus on a person and try and address their needs. Next slide. This is the second image that we had in here, and it was really just kind of trying to convey visually a little bit about how digital health can kind of build some of these aspects of what we're trying to achieve, how it can pull information together, how it can create relationship networks for care teams and families and patients and communities, how it can then communicate across settings and over time in between people and team members, make sense of the different information, and then apply all of this to get better outcomes around patient-oriented outcomes, efficiency and value of care, and health professionals' quality of life. Next slide. So with that as the background, the committee came up with 2 recommendations, 2 actions that they thought were important. And these are very broad and they're very conceptual about sort of what's needed. And there's a lot of ways to kind of get to how these might be achieved. And the report talks some about how we might get to these ways of achieving these actions. But there's a number of things and details that need to be figured out. So the first action is about developing the next phase of digital health certification standards. And having implemented meaningful use in my health system, collecting the measures and reporting it to CMS, I have a little anxiety with this one, but it's fundamentally kind of different from what's happened in the past. It's really about implementing this next phase that's based on primary care's needs. So relationship-based, continuous, person-centered. It's supposed to make the user experience easier, not harder, not create more work. It's supposed to ensure equitable access and use of systems. We know there's a digital divide, and we know that we have to do something about this. And instead of holding individual clinicians and practices and health systems accountable, really the folks who are developing and promoting and delivering digital health systems need to be held more accountable as part of this process. The second action that we asked for, which is also an equally big ask, is about adopting a comprehensive aggregate patient data system that's usable by any certified digital health tool by patients, families, clinicians, and care team members. And it really is getting at the concept of breaking up our silos of information and not having an individual clinician have to manually break down the silos of information to create this comprehensive aggregate record. This should be easily accessible at the point of care in real time. Now let's delve into these different elements. If we go to the next slide, when we talk about that first action, this next phase of certification, so we're talking about aligning with functions of primary care, so supporting relationships, providing access and continuous contact over time, collecting and understanding stories, and then shifting from a disease focus to a person, patient, family-centric focus. Next slide. The other part of the certification that we're thinking about is actually improving and reducing clinician workflow. So this is about this overarching concept of making the right care at the right time easy to deliver. And so we put automate, automate, automate. You know, why should it require a lot of manual activity to do this? That's sort of the advantage of digital health, of trying to make the process simpler and more automatic. That also includes sorting through that information like we talked about and making sense of the information. Next slide. And then we need to change the model of accountability. And some of this is about defining metrics of success. And I'm going to get to that again when we start talking about the scorecard. But this is a really important part of this. It's about automating measures based on the lived experience. So I can remember with meaningful use, being able to demonstrate that my system could share information, that we could participate in health information exchanges. But we need to measure the lived experience. Is information actually being shared? And is it being shared without having to manually reconcile lots of information and things? And that should be captured automatically. It shouldn't require an extra process to demonstrate and verify that this is happening. And then, as I said, part of the recommendation was to hold vendors and state and national support agencies accountable. So we start building these platforms that people can tap into that will really achieve the goals that we want to achieve. Next slide. So now talking about the comprehensive data, this is a big ask, and we know that this is a big ask, and others have asked for this in the past, so it's not necessarily a new ask, but it really is central. Earlier we were talking a little bit, and data is really powerful, and access to data and controlling data is very powerful. And it is a tool that information systems and health systems actually use to kind of retain power, but it does undermine quality of care that we can provide for people. We don't want clinicians who need to make decisions and help people to have their hand tied behind their back because they don't have access to all of the information from the source of where that information was generated. So we talked about different ways that this could be achieved, and very much there was a feeling that this isn't a technical issue. All of these processes are available and they're in place in different sectors, and they're actually in place in different countries right now for health information as well. So a lot of this is a policy issue. There are clearly issues around privacy and other things that we need to be thinking about. But there's different paths that we could achieve this at. So one might be a centralized comprehensive data warehouse. Spain and some other countries have done this, having all of a patient's information be as it's collected, going to a central place that could be used and accessed. Another could be the idea of this individual health data card, or this could be like your operating system on your phone that actually stores your data under a person's control. Or it could be distributed sources connected by a real-time functional health information exchange. And this latter option is largely how we have selected to be moving forward, but the italicized real-time functional is what's critical here. So it has to be accessible at the point of care when it's needed to make these decisions and to help people. Next slide. So, on a conceptual level, some of the core principles that we talked about is that whichever path is pursued, clearly patients should have control of their information, and it should be patient directed as to who has access to information and what information people access. But then with the patient's permission, any care team member should be able to access this information. And in our other sections in the report, we talked about care teams and shifting from doctors providing services to teams caring for people. And so that team access is very important, and that extends beyond the healthcare system and includes community and community organizations as well. And then similarly, if you're developing this, any type of a digital health system that is kind of meeting the needs and demands should be able to access this data and use it to function this. We often hear about the example of our banking system and, our health, digital health and information exchange should be like our banking system. But we don't often talk about sort of the opposite. What would it look like if our banking systems look like our digital health systems today? Think about it. If you deposited a check in one bank and you wanted to go to an ATM or another bank and take your money out, if it looked like our digital health system, you would actually have to bring your proof that that information was in the bank, show this other bank or ATM that you had it there before they could feel confident to access it. And then they would have to create the connection to your original bank in order to be able to access and to do anything. And every individual and every system would have to create their own connections, and there'd be a lot of manual steps to prove what's happening. And I know I'm saying that in a little bit of a bleak way, and the outlook is actually much better than that right now. But it gives you a little bit of a feel for kind of where we're at versus where we need to go here. So next slide. And I'm going to, last bit will be quicker, Asaf. I won't get us behind too much here. This is our scorecard here. And so we tried to create a scorecard for each measure, and we tried to use metrics that were already in use, keep them few in number, make them easy to understand and consistent, and build on data that's regularly collected and is publicly available. What you see on the right-hand side of the screen is that we said for digital health, we're not aware of any measures that meet this. And this actually ties into sort of that first recommendation and that digital certification. That should be sort of a starting point and a basis for thinking about what are the metrics that really define that we're succeeding with digital health, because they don't exist and they're not normally collected on a regular basis right now. Next slide. Here were a couple parting thoughts that I had about paths to success. One is primary care needs a voice in leading this. And part of our recommendations around the Secretary's Council on Primary Care and primary care research would give primary care a voice. But I think if primary care is a foundational user to digital health, they need foundational input on this. Data's power, and access to data can be both a carrot and a stick to hold entities accountable to make sure that they're meeting the needs and doing what we're wanting them to do. And then we really need metrics and a scorecard to define success, and that can be the next phase of digital health. And I believe that gets us to the end of this section, Asaf.
Thank you so much, Alex. Really appreciate, going over a series of complex topics and sort of big recommendations. On the committee, we talked a lot about how we tried to aim to be pragmatically bold or boldly pragmatic, depending on, your purview. And so this certainly is in line with that. I wanted to turn the floor over to Brenda, from your leadership, research and practice positions in in a health system. Can you talk about the role of a well-functioning IT system on really being able to implement integrated team-based care?
Yes, thank you very much. It's a great opportunity to share what I believe we feel is the future of primary care, and the future is here. And that is the role that a high-functioning integrated team needs to be able to perform with high-functioning digital health. And at Intermountain, we have had an incredible capacity of a data warehouse, of longitudinal registries, of data that was transparent and available for teams to really look at and continue their performance over time, and really measure the experience of not only patients and families receiving care, but the burden of providers and the teams providing care. But I think there are two really, really critical points in terms of being able for technology to keep up with the connections that are needed. And that is that technology needs to take on the challenge in terms of integrated digital health. And this needs to be able to move from the silos of some of the technologies that Alex was referring to, in terms of we have this piece over here and this piece over here and this piece over here, and really be able to build not just a common good for all, but a common business plan for all. And that the business and the opportunity that's available in technology, it is going so fast, we are connecting in a different way. And I think we are hearing from consumers and patients and families that they want connection. Teams want connection. And the opportunity that we have to be able to allocate and distribute the workforce and the team resources is going to be not only predicated on payment reform that we've already talked about in our webinars, but also digital health reform and the ability to have the data that you need to be able to, and I'm not just talking about claims data, I'm talking about the lived experience of patients and families, of providers, being able to look at their experience, make the transformation that's needed, and then move it forward to a better performance. And the last thing I will mention is the importance of the data not only being real time, but longitudinal, being able to measure over time the impact of continuous whole person integrated team-based care. And this speaks to and I've been interested to see what our panelists feel about this, can our digital capacities, can our technology build upon the trust that people want to have with can it feel personal? You want a personal connection with your physician, with your provider, with your nurse practitioner, or as we talked in the workforce, it could be the community health worker. Can the digital technology build a network that builds trust along that network and makes all of the team folks feel that they are contributing value to the outcomes? And the last thing, I think I already said the last thing, but the outcomes, I think, are really critical in being able to feed those back to the entities that are investing in the new way that we are connecting, and be able to see that real time, that people have had a return on their investment over time. Patients and families are members of the team, and they bring assets to the team, a lived experience that will help us move this forward. And I think I'll end my comments on that. I think Alex and Asaf, you did a great job teeing it up, and I look forward to hearing from the panel.
Thank you so much, Brenda. I mean, I've really appreciated working with you and learning from you and the rest of the panel, the rest of the committee members. And, you know, this is an overarching comment question to our panelists, and then we'll get to each of you. But, you know, I think that Brenda's highlighting the fact that we have, in a good way, a convergent set of needs and vision for how we want to use the powerful tools of information technology to build and improve a relationship-based, longitudinal primary care system of the future. We have a common set of needs and wants around trust and data accessibility and aggregation and analytics. It's just the how that is confounding. And I'd love to, you know, as I turn it over to the panelists, I'd love for you to be thinking about, okay, if we have a general theory of the case here on what we want to build, why is it so hard? But let's maybe focus less on the why and the how to build it better. And I guess, you know, with that, I might start with Andy. And by the way, you know, one theme of the moderator's prerogative is we have so many great questions for each of you. I'd love for you to think about maybe answering in less time than it takes me to order a few lab orders and 19 clicks for a screening mechanism in my notes. So, you know, we'll keep the answers short to kind of move things along, because we have so many great questions to hear from you about and then from our audience. But Andy, let's start, you know, again, this idea of the aggregate patient data system option. You know, the committee's talked about data cards. We pointed to real world examples, patient data cards, centralized data warehouses, functional real-time patient exchange. Again, common vision, hard to implement. What are the pros and cons of this? But more importantly, how do we make this feasible, if it is feasible at all?
Great question, challenging question. Thanks for having me first. Very appreciative. And I'm going to try and be quick. I'm going to touch on some of the ingredients that we believe we've already put into the regulatory space that will facilitate and enable some of that. And that is actually what Congress initiated 5 years ago now, when they passed the legislation that basically said information is going to flow. There will be interoperability. We haven't achieved it yet. Then we spent about 4 years, a little bit of delay because of the pandemic in terms of timing, to put in concepts such as USCDI, the United States Core Data for Interoperability, which is required to be shared now through open APIs, application programming interfaces, using a standard, FHIR. Now, that sounds like a bunch of technical jargon, but what it basically says is the rules around doing that are now in place. And in order to affect what you're talking about, you have to have some of those rules. Now, what if organizations just say, not for me, I'm not going to do that? Well, the other thing Congress did is Congress put a huge penalty on those individual entities that historically didn't share quite so well. So HIPAA 1996 gave patients access, put privacy in, but allowed health insurance information to move. It didn't really speak to some of the clinical content, but in order to do that, it was almost impossible. You had to go to a medical records department and limited hours. There were costs involved. Now, with open APIs, the patient's in control, and all of that can happen very, very quickly. A lot of questions about it. So what will force somebody to do that? The $1 million potential penalty per episode, which is applied to healthcare networks that stand in the way, and individual clinicians and systems and healthcare entities have yet to have the consequences defined, but health IT developers, networks, those are really powerful things. And OIG, who's pretty good in enforcing, is charged with doing that. ONC, my former organization, said, well, not everything. There are a couple of circumstances. And we promulgated a bunch of regulations that enumerated what those circumstances were, where it was okay not to share. But all of those are predicated on you must be sharing. And then there are some exceptions. But the fundamental belief is you got to share. And that's going to be very powerful. I haven't directly answered your questions. I actually have some reservations about a large-scale aggregated data, especially in this time of problems with technology and sort of hacking and stuff being held in ransomware. So I'm a little bit cautious about that. What I am excited about is some of the, and not all HIEs are the same, but some of the HIEs in the middle of the pandemic really did some fabulous work with their data and their populations. And NIH, the National Cancer Institute, has developed some technology for privacy sparing, so that you can aggregate large volumes of information from disparate sources and still have them protected and not just put in a single place. I'll stop there because you asked me to be brief. Thanks.
Appreciate it, and appreciate the candor and also the sort of attention to emerging risk about the aggregation in the aggregator itself as something to be wary and aware of. Josh, if I can turn to you, I bet you would agree with the idea and that private sector and the vendors are working hard to make health IT more person-centered because that's what customers want. But so what is needed from your perspective to develop more truly interoperable products, and what role or what needs to happen at the federal and state level, again, to interface with the private market to kind of achieve that shared goal?
Sure. So a lot of the challenge here is articulating a positive vision for what does that true interoperability look like? And I actually would push back and say it's a very slippery concept. We tend to use that label when we're frustrated with how the things that we've already built aren't working for us today. We say, well, sure, that's interoperability, but it's not true interop. It's not what I mean. But actually putting a pin on that concept of what you really want and being specific about it and writing down rules, that can be an incredibly frustrating and slow process. So if I look at what we've laid out today, I think that we have more a set of capabilities around person-centered records than we do an overarching architecture that explains how to tie those capabilities together and build functional systems for ingestion and analysis and communication downstream. But we oftentimes do well to say, we know what the sort of end of the line looks like. We're not sure how to get there, but there's a few things that we think are on the way. So giving people access to their own healthcare records, making sure that the data that we know how to standardize are widely shared. Those have been the focus of this current round of regulations and the very good work building on the Cures Act from ONC's final rules last year to say everyone should have access to this core data set. Medications and problems and labs and allergies and the kind of stuff that's been at the center of our summary records for a long time. But I want to call out the distinction between read-only access to a core data set versus being able to truly move data back and forth across many different entities with different organizational boundaries and controls. We can build technologies that enable a lot of these capabilities. And we see, there's hundreds of certified electronic health record vendors today that have built APIs to meet those ONC requirements. But what's the next layer of functionality that we really want to get out of this? And this is a place where being very specific helps a lot. So we can drill into use cases like management of hypertension or diabetes and take a disease focus and say, what are the kinds of comprehensive care programs that really make a difference, and start thinking about metrics there. Or from the other perspective, we can drill into some of the usability requirements and try to understand, what are some of the aspects that make a system more usable. But there's a risk anytime we try to do this design and bake these into regulations, that the regulations or the certification programs overfit. All right. So when we talk about counting clicks, for example, sure, everybody agrees that all else being equal, I should be able to place this lab order using fewer clicks. Makes sense. But if you start focusing that as a regulatory target, you might miss really important areas of the solution space, because now you've got vendors driving down click counts maniacally with a strong focus, and those click counts will be reduced. But maybe there's a whole slew of automated ordering that's based on protocols where you don't even need to take any steps that people aren't paying attention to because they're so busy meeting those regulatory requirements over here, checking the boxes. So those are some of the tensions as I see them, and I'm happy to drill in further if it makes sense.
Oh, absolutely. And I appreciate what I hear you saying is that the issue is less that the technology cannot be built or made to achieve the goals, but really the issue is with clear problem articulation, convergent shared problem articulation, and then what's the goal and what are we building towards, which in our cacophonous, heterogeneous healthcare system is a little tricky, not just in digital health. I think that relates to the question I have next for Sean, which is, we've heard today on the call, we see it in the Q&A in the chat, about what it actually means, some of the barriers, how to accept data in PDF and fax form from, the end of the 20th century into 21st century records. So can you talk about, not just the barriers that the practices working with Aledade face, but really in terms of aggregating data from disparate sources, but what you've seen work to address some of these data. Again, hearkening back to these themes that Josh and Andy are getting to about, crisp, convergent problem definition to design the regulatory infrastructure for better technology as opposed to just making a technology solution.
Sure. Thanks for that question, Asaf. First, just for context, for those who don't know, I'm at Aledade. We work with about 8,000 primary care physicians around the country. These are independent primary care practices, and they're all involved in value-based contracts. And what that means is they're trying to provide comprehensive, continuous, coordinated primary care. And so everything in this report resonated tremendously with them. And we run into, as you suggest, Asaf, we've run into lots of everyday problems as we try to build a digital infrastructure around these practices, whether it's getting the local hospital to share an ADT feed so the practice knows where their patient is, or, we've literally built a population health tool that's the second screen in these practices because we can't get it to work with so many EHRs, and none of the EHRs have these capabilities. But what we try to do at Aledade is not focus on these proximate causes, why is this so hard? Why do we feel like we're swimming upstream? Why are we calling for all sorts of regulations to solve problems that are technologically not that difficult? And what we feel is, if you go upstream, why isn't this system working? The answer is pretty simple. One, we're talking about building a digital infrastructure to support a type of care that essentially the system doesn't pay for. The system isn't demanding the type of care that needs all these tools. And so you can be very successful in the American healthcare system without using this stuff. And that's why ONC and CMS come in and say, you got to use this, you got to use this. And people are like, I don't have to use it. You're paying me for volume. And then the second thing is the other context that's really important. If we want, primary care to be a public good, doing all these virtuous things, we got to remember the context is a healthcare system that's incredibly consolidated. Again, and there was just a report in Health Affairs, independent practices that come into these consolidated systems, whether purchased or brought into a CIN, they get higher payment rates automatically. Quality of care is no better. So people have figured out a pathway to success that doesn't require digital tools and better care. And until we're paying for better care at lower cost, all the everything we're doing to create the tools that deliver that will be swimming upstream. So one thing we're doing at Aledade is just that. We don't work with employed, CINs. We do feel like the independent physicians are aligned with value, but we're such a small segment of the ecosystem that no one's building digital tools to cater to this. So I apologize for getting out of the very technological focus, but Asaf, you said this report was technologically bold. It's actually not. It's bold in other ways, in that it's so swimming against the current of where everything is headed. But technologically, all these are solvable problems. The problem that's harder is, how do you solve healthcare consolidation that makes activities that don't drive better care at lower cost successful?
Yeah, I really appreciate that, Sean. Both the committee in its discussion and look at the 6,000 pieces of evidence and 3 open committee meetings and lots of stakeholder and patient views, really settled on this idea that you first start with a parsimonious, or at least shared vision of the system you want to build. And then, that slide with the 5 recommendation is ordinal. It does, the committee definitely felt, to what you're saying, that it's not that payment is the most important thing, but if you do not create the fiscal space tied to the type of primary care within the type of health system that you wish to build, everything else will follow a set of unanticipated or anticipated consequences that won't get folks to harness technology within the context of teams for patients. So I think there's a lot there. It is bold maybe to say that we actually have to reorient the whole way in which the delivery of care should drive the changes you make in payment, as opposed to the payment drive. Currently our antiquated payment system just drives this delivery system, not the other way around. So getting to part of that delivery system, Andy, and by the way, we're seeing lots of questions about, automation of performance measure. But even before you get to performance measure, you actually have to collect data about performance. And, we know that primary care collects a lot, maybe a plurality, maybe a majority, I don't know, but a lot of data about the longitudinal experience of patients across the health system. And yet, it arguably doesn't really have a clear agent within ONC or other HHS agencies to focus on harnessing the power of that data to turn it into regulations around clinical decision support, population health monitoring, public health integration. And we saw that lack of integration between public health and clinical care have a major impact in COVID. So who in HHS could do that, or what would it take to inspire, a better approach to perhaps harnessing that data to be used for those functions?
Oh, that's a great question. Thank you for posing it. It's also a difficult question. I would point you back about 24 months ago when we released the report back to Congress on reducing clinician burden. In that, we actually talked about sort of this manual process to satisfy regulatory reporting requirements, quality reporting requirements, billing requirements, and we worked jointly, ONC and CMS worked jointly to actually make the first substantial change in the E&M ambulatory coding requirements in over 20 years, which is to take away the requirements. You need so many of this and so many of that in the history of the present illness and the physical exam and the review of systems, that you don't have to duplicate things that are otherwise in the record done by other folks. And our original proposal was actually even more substantive than that. And there was some reaction from certain parties, stakeholders in the industry that pushed back. It was a campaign of disinformation from my personal perspective that was effective. So some of these changes don't happen quickly. In terms of the quality reporting construct, that's one of the things that you called out. We believe that it is certainly possible to achieve that without the actual users of the system, the clinicians caring for patients, others involved in the care to actually do anything. But the data needs to then be available. It needs to be precise and defined accurately and implemented consistently for third parties to be able to interrogate that, probably with the permission of whatever entity is holding that. And we thought through a number of the policy changes that would be necessary in order to encourage that. So we're thinking in that way, and I don't know that there needs to be another entity beyond ONC and CMS working concurrently. What is interesting, though, if you think about the regulatory space, ONC has a voluntary certification of the EHR developer community. CMS has requirements for billing clinicians, billing providers, and incentives. But in the middle, there's a void of anybody regulating or setting standards or doing something around the actual implementation and configuration and operation of these systems. And so what you see going from place to place, as we frequently did, was all kinds of variations. Now, I'm at Dartmouth, so variation is bad and standardization is good, and then you learn to see what works better. Jack Wenberg would be happy with me for saying that. There really is, and I don't want to say a regulatory void because I'm not personally enthused about a lot of additional regulations, but we need to have methodologies to make sure that not just the implementation is done effectively, but also the ongoing upgrades. And as people move from one system to another system, that is done safely and securely in order to achieve some of those goals. So I'll stop there with dancing around some of the questions.
Well, anytime you can, get in a reference to Jack's work and variability in an EHR discussion, I appreciate it. So you get extra points for that one. Just another request, and we're getting great questions in the Q&A from the audience, so keep piling them in. I'm trying to integrate them into what I'm asking the panelists, but in just a couple minutes, we're really going to take them directly from you. Josh, a number of the questions in the Q&A are in some quite poignant. Primary care clinicians who are saying, look, I want to do my work. I know what primary care can do. It's not just as simple as blaming the EHR technologies, but they're not helping. And in fact, they're making people burn out. I mean, the 2-to-1 ratios are well known, 2 hours of charting and EHR work for every hour of direct patient care. And what I heard from you earlier was that, we need to have a clearer problem articulation and set of where we're building toward, and then we can build toward that in a set of market forces. But how do we get out of the chicken and egg dynamic, at least from the private perspective? The market is going to build to what sells in the market and what achieves, minimal aims at lowest cost. What elements within the private sector can be utilized to kind of aim toward this more expansive notion of what technology can do, even amongst the cacophony of perhaps not shared goals? If that's making sense, love your thoughts on that.
Yeah, so first of all, I think that Sean really put his finger very clearly on the challenge, which is the incentive structures underlying how a lot of these systems are designed and how they're sold and whom they're sold to. I'll say that from one perspective, you would think if the market was transparent and efficient, then primary care users would have access to a marketplace of different vendors and services that they could choose from, and there would be competition that made these things more usable and more of a pleasure to use every day. We see in reality things change slowly. It's often because there's a lot of different things these systems are trying to do. Many of them tie back to billing requirements or other regulations around data management and use. Oftentimes, outside of the context of a small primary care practice, these systems are purchased from an administrative angle that sort of brings a clinical perspective in, but not necessarily from a clinical perspective first. And there's tension between what these systems can do to support some administrative and some clinical use cases. So that's all challenging. And one of the questions is why are things so slow to change? One perspective would be, well, the switching costs are high, particularly for large organizations with big IT budgets that spend years implementing a vendor product. The notion of switching to a different vendor product is something so expensive and slow that it gets put off forever. It's not feasible in the short or the medium term. Even for small practices, that problem doesn't necessarily shrink with the size of the practice, because smaller practices tend to have, smaller data sets and less custom integration, but also less sophistication and IT staff to help manage those transitions. So it's not like the problem of switching scales down with the size of the practice. What I would say is that there's a lot of power in changing the baseline requirements so that any system out of the box supports a greater degree of modularity and flexibility, so that even if you can't easily switch out your EHR, you can still layer on a new functionality that helps you accomplish specific goals. So these could be things like automated encounter sort of ambient intelligence solutions. These could be things like chatbots that help triage a patient before they show up at the clinic, or help follow up with aftercare visit information. And these are all sort of technological components that you can plug into a base EHR system if the right pieces are there. But at the same time, when you look at some of those technology requirements or some of the API functionality that you would need to have in place, the pieces that we have regulated today are only one component of that overall design space. And so if you're trying to build just against those APIs, there's a limited set of things you can do. Today, they're mostly focused on viewing or visualizing data or analyzing or making sense of information downstream. It's much harder to do these kinds of workflow integrations like writing a note or preparing a set of orders or evaluating and changing care plans in real time. Those require more functionality from the core system than we have as a baseline through our regulations. Improving that baseline is something that's very slow. So like realistically, that's the kind of thing that could take 5 years or 10 years of careful work. If you look at the timeline that it's taken us to get there with the Smart on Fire APIs, that was about a decade. If you've got a much more focused problem space, maybe that's something you can do in 2 or 3 years. But we need to calibrate to those kind of realistic timeframes for working together across different vendor products, setting some very clear goals, deriving functional targets from regulations to say, here's the kinds of capabilities we want these systems to have, even if we don't lock down the particular technologies and standards. But at the same time, to have a force saying, yes, we're locking in these functional requirements today, but we're going to have standards for these in 3 years. So we don't want industry to go off and develop 300 different solutions to these functional requirements. We want industry to go innovate, but understanding that we're going to be driving towards convergence. And that whole blend is something that I think we've got a few good examples of driving through, but we also have, let's say, a lot of examples of where that process can break down.
And thanks so much, Josh. I'm going to ask one more question to Sean, and then we are going to enter a lightning round where I'm just going to throw out questions for any of you to opine and talk to each other about, and then we'll move to the part from the audience. So Sean, Josh mentioned a lot about the use case and the often, I think, all too forgotten use case of the small primary care and small practice in general. What's specific? So in the non-enterprise level EHR systems, what's specific in your observations that's not working besides aligned payment for these practices as it relates to IT, and what solution set might you point to, given your experience with 8,000 of these practices around, or 8,000 of these folks around, making it more doable, more functional, more patient-centered?
Yeah, that's an excellent question. I really appreciated a lot of what Josh had to say. He's describing a world that would work really well for us. But I keep going back to, like, what's the problem? My practice, we've got practices in rural Arkansas. What's the problem they're having tomorrow? The problem they're having tomorrow is the local hospital won't send them an ADT notification. Not a technological problem. It's not even a payment problem, like, because the hospital, no one's really getting paid for an ADT notification. It's a societal problem that hospital's decided, I don't really care what happens to these patients. They're not my patients. Or, God forbid, that primary care physician is going to prevent a readmission. So why should I give them an ADT notification? Like, it's so environmental, the problem that our practices are facing. So I love the vision of this report. I love the vision that Josh just laid out, and our practices would eat this stuff up. And I apologize for being very pedestrian, but, and let me give you an example. The reason I think it's so societal is there's actually now a condition of participation in Medicare that says the hospitals have to provide an ADT notification. But the hospitals have gotten ahead of it and said, well, we read it as meaning if the patient asks that my primary care doctor be notified, and yeah, Dr. Purifoy sent me a list of all his patients, but I'm going to ignore that because I don't read the regulations. Like, I don't think we can regulate our way out of this problem. I think we need a bigger picture discussion. And I think this report starts that discussion of how do I get that hospital to want that patient to be healthier? And then we'll build the technology to fit that. But the problem right now is that hospital doesn't care about that patient, even though it's in their community, because it's not in their interest to care about that patient.
Yeah, thanks so much, Josh. It looks like you have your hand raised to chime in.
Yeah, I just wanted to make a quick comment. So first of all, I totally agree with Sean's kind of root cause diagnosis here. But I also want to highlight that there is some room for very clear technical improvement. So something like ADT, admission discharge transfer notifications, is a standard that allows one party to broadcast out these notifications to specific other parties. But it actually doesn't include a mechanism for anyone to register their interest or subscribe to these notifications. So the fact that we've chosen a standard to solve this problem that only solves the announcement part and doesn't actually solve the subscriptions part means that everybody's building totally different systems. So when Dr. X wants to send their list of patients to the hospital, every doctor might be doing that differently, or every hospital might want different data formats. And that's a place where having some clear standards in place, not just for the announcements, but for the subscriptions as well, would limit, let's say, the aperture for hospitals to delay or defer or say no. It's still a deeply social problem. I'm not trying to deny this, but choosing the right technologies can help.
Thanks so much, Josh. All right, lightning round, even pithier, and anyone jump in. First question for the panel. Alex really challenged us all. He said, what would banking and ATM transactions look like if they functioned like EHRs? So, anyone want to take that on, Andy? I bet you have some thoughts about that.
So I'm old enough to have experienced the banking industry when it was just like healthcare, where your ATM card only worked at your one bank and you had to drive all over the place. And heaven help you that you were traveling and tried to find someone in the network. So we forget that what we're talking about now is an industry, healthcare IT, that is relatively young. Oh, by the way, the banking industry, in order to achieve their transformation, spent 12 to 14%, depending on which numbers you look at, of their operating budget for 5 years. And they currently spend 7 to 8% of their operating budget in technology. Just for a frame of reference, healthcare systems tend to spend 2.5%, maybe 3% of their budget for all IT, not just the clinical IT. So we have what I used to call prime rib appetites and chopped meat budgets.
It sounds like maybe even baked bean budgets, but we can decide if you're an omnivore or carnivore. Any others to the ATM and EHR question, or should we keep moving to the next ones?
Apparently, I'm older than Andy, because I remember before ATM machines at all, when you would drive up and you'd put your information in a pneumatic tube that would get sucked up into the bank. And I guess we're not that far away from that with fax machines. So.
Hey, Asaf, I want to add in something. I know I charged the group with that example, but I wanted to build a little on what I heard folks talking about and thinking some about policies. And I generally don't like lots of policies and rules and regulations. I think that can make things tricky. But, COVID and telehealth is a really interesting example. So, and me as a family doc, I had telehealth and was offering it to my patients for 3 or 4 years before the pandemic. And the uptake was so low. And 3 things happened when the pandemic hit to really change telehealth fundamentally. So there was, the payment parity for telehealth visits. My office manager was always terrified you're going to see someone and you're not going to get paid for it. And so that's example of the practice follows funding. We relaxed the regulations on the HIPAA so that you could really crack open the telehealth systems and use something that worked better, but maybe wasn't a traditional medically on the traditional medical pathway. And we relaxed some of the regulations about documentation and where you can see people and these other types of issues. We removed these barriers, and like my practice, like many others, we went from 1% of our visits were telehealth or less to 100% in 2 weeks. 2 weeks. I mean, that clearly shows this isn't a technical issue. Sort of a process policy barrier. What do we want to achieve? There was a cultural thing. Patients wanted telehealth. They didn't want to come to the doctor's office. And we were trying to promote, self-quarantining, social distancing. So there's all this good kind of working together. But if we think of that as an analogy, it starts to give us some ideas about what it might take to make things truly interoperable, to truly develop some of these things in a much more meaningful way. I think there are barriers in place. I've switched EMRs 4 times in my career, and my fear with switching EMRs is data loss. the whole ADT, PAMI data, that's great. That can go. I'm not worried about diagnoses, allergies, med lists. That's what you can get on the patient required feed. It's all the other data that's lost. That's truly meaningful. The MRI reports, the notes from different folks, the depth that's there. That's what we don't have and what we haven't agreed to kind of share and make open. And until we make that completely open, my decision to switch systems is not based on which systems and which technological solutions work best. It's my fear of losing thousands of hours of data entry that I've done over 5 years. And thousands is actually the wrong term. It's probably tens, if not hundreds of thousands, if you count everyone in my office.
Yeah.
That's the problem there.
Yeah. Josh and then Brenda.
Yeah, I just wanted to make a quick comment around the consumer experience in particular of trying to aggregate records. And actually, I think the story in the financial world is not that different from the story in the health world when it comes to bringing your records together in one place from multiple bank accounts or multiple investment accounts. The options in the consumer space are things like mint.com or personal capital, where you basically go one by one through your banks or your accounts and elect to share your data. Oftentimes, those systems don't provide the best kind of guarantees around scoped data sharing. Oftentimes, the way they work in the financial world is you literally provide your bank username and password to these aggregator tools, and then they go in and sign in as you. At least in the healthcare world, where we're rolling out these APIs, rather than sharing your username and your password with every app that you want to bring data into, we can use a standardized authorization flow where you just give app access to the permission that it needs. So I think when you drill into the details, it's actually not such a simple story, and the dichotomy isn't actually that clear.
Yeah, and I can feel through the electron channels Andy's blood pressure rising on all that single password, data aggregation. Though I know there'd be safety mechanisms. But all joking aside, Brenda, I saw you had a comment, and then I have one more question. I'll hand it over to the audience.
Yes, just to add to the COVID experience and telehealth and the integration of mental health and psychiatry. The opportunity that's happened, the businesses that have erupted across the country for contacting and being able to have telehealth consultations has been enormous. And I guess my concern for us and the conversation moving forward is what Andy talked about earlier. Is this fitting into an implementation methodology that will build upon? Did those contacts result in an integrated team-based care approach that actually produced whole person-centered care, decreased cost, and improved quality? And we don't know that. And we don't know that because of the siloed ways that the telehealth or the mental health apps or the social health apps are all being laid down upon, disparate different systems. But it's also a good sign of how fast it could happen and how fast the policies could be removed. And the momentum that's happened with that is really something that I think that we should capitalize on, but get back to an implementation methodology that's a long-term vision of where this is all leading to, and build the business case to eventually integrate social health, dental health, mental health, all the things we know that primary care is the first contact, but can give a continuous way forward for the population to stay healthy.
Thank you, Brenda. Right. If we think, ordering some labs and having some longitudinal notes and MRIs are tough, integrating those other data feeds and actually integrating with public health. Wow. Okay, my last lightning round question is the following for any and all of you. Actually, I'd love for all of you to chime in. So this has been an unusual panel because we have this big, gnarly topic. And I would submit to you, panelists, that you've been in wild general agreement with each other, at least on the outline. So we know that if you're in wild agreement, at least on the big subjects, it's still going to be so hard to do. The details, as Josh and others said, matter so much. There's so many players, so many resistors. What are one or two things that you are excited about, that you want to share with us, that, not in the report or sort of, coming down the line, or this coming political convergence or sort of Shangri-La around getting through these well-documented barriers. It's kind of easy and almost comfortable to tell everyone why it's going to be so hard, but what are you excited about? What are you working on? What do you know about that has the potential with the right stakeholders to kind of break through and build IT for the users that we know we all need?
So if I'm going to jump in, I can't raise my hand because I guess I was a speaker, so they didn't give me a hand raising function. So I'll give Andy and Josh and Sean and Brenda a second to think. And I'll tell you what I'm excited about. It relates to what Andy and Josh and everyone talk about, sort of patient requested data. I think we have seen big improvements in people being able to request their data. And there are now apps and tools and things like that let people request their data. What made me excited about that is, early on and when I was working with the IT things, big things we did was to show patients their health information. We kind of cracked open the EMRs and parsed their information and showed it to patients. And that patient demand was the biggest driver for among our doctors and practices. Like, patients would go log into their record and say, well, the doctor just told me I'm up on my colonoscopy, but here it says I haven't had one. What's wrong? And the doctor entered it in the wrong field. And you know what? The doctor changed. The moment the patient comes in and says, you're not recording my information right, the doctors change. I think the same can happen on a broad macro level around access to information. And I think people need to be demanding that their access is available and accessible when they want, by whom they want. And I think the more that we kind of start to open that up, that'll create a cultural change, which I think is going to really push everyone to change.
Thanks, Alex. Others, breaking the log jam, things you're excited about.
So I'm excited about the solving the problem of getting data into the systems, because I'm starting to see, whether it's ambient technology or other technologies, the ability for technology to facilitate the clinical encounter. And that's important because we've lost the narrative in many of the notes that we see generated as point and click notes. And it also gives us the opportunity, I think, as Alex wants, to be able to think about the patient as opposed to an actual encounter. So it's, having had the experience of leading the development of an electronic health record at Dartmouth many, many years before we switched to Epic. Our clinicians really loved their electronic health record because it was centered around the patient. And it wasn't centered around an encounter. And when we moved to Epic, I was really excited about the construct of encounters, because now we could look at the labs and the meds that were ordered around which visit and understand that. The reality is it created all of these silos, so that you have to find the referring notes, 15 clicks away. I'm sorry, Josh, I did the click thing. But it made the records unusable. So I'm excited about technology making that better again and making the patient the center of the focus of the documentation.
Others?
I will add to that, Andy. What I'm excited about is how fast technology and our social awareness has increased, so that we are building more cultural tolerance for complexity. And until we have tolerance for the complexity of the lived experience of each patient, each family, each provider, each population, each clinic, each community, and not only the disparities, but the opportunity to actually embrace diversity and really use the complexity to our advantage. And there is great science in terms of complexity science and implementation science that now we can pull from, where we actually can look at the experience of others and use that to build the technology that we need. I'm also excited about the opportunity that technology brings to decreasing the isolation that we feel and that families and folks feel in our society. And after working for over 40 years in primary care, seeing physicians and providers that felt isolated, seeing patients and families that felt isolated and people suffering in isolation on their own, there is no reason in this country why people should be suffering on their own. And I think that technology and the open message of a common good and a common will to share. I mean, we're talking about sharing technology, but we're also about sharing networks and communities. And I think technology has shown us that. Look at all the connections and social media that I know there's good stuff and bad stuff, but the main thing is people are connecting, and it's in our evolutionary best interest to connect. And we are social beings, and the best way that we can do that is to move forward and use technology as a resource to connect us in better ways and get the outcomes that we need for each of our communities.
Just briefly on my side, if I've made clear that consolidation is my great fear and what I think is preventing us from getting better care at lower costs, the things that offer some hope are, one, I think Andy mentioned the growing consumer movement, which I think is somewhat tech enabled, but is a positive force. Two, an economy-wide growing interest in antitrust enforcement. And three, a growing realization that primary care really, and most of the alternative payment models being tested in Medicare and elsewhere, really independent primary care docs are really the ones generating results, and NASM and others building on that and suggesting payment reforms around that, I think offer hope as well.
Thank you. Josh.
Sure. So I'm going to point to just a few building blocks that I think are quite powerful and that I'm excited about. Number one is a technology called CDS hooks, clinical decision support hooks, which provides kind of a common way for an electronic health record system to reach out deep into a particular workflow and bring external advice back to a clinician, which could include making tweaks to existing orders or launching a relevant app that's going to help make a better decision. So that's CDS hooks. Next one I would point to is a project called Smart Health Cards, which is all about giving consumers access to a copy of their own information in a way that they can store and share downstream, and in a way that is verifiable. And so a lot of interest has been driven by COVID-19 use cases like vaccine verification. And that's something that went live in California for everyone who received a vaccine there last week. But the technology is not specific to vaccines. And I'm quite excited about this as a kind of a very small scale PHR technology. And then the last thing that I'll point to is on the regulatory horizon, which is the capability called EHI export in the ONC Cures final rules. And this is about, to Sean's point, the everything else beyond the common summary data of meds, labs, problems, allergies. This is the everything else. And it provides the requirement that EHRs need a way to export all that stuff. And it doesn't have to be standardized because by definition, we might not know how to standardize it today. But if it's stored in the EHR in a structured way, it needs to come out in a structured way, and that structure needs to be documented. And I think that's going to be a very important capability for leveling the playing field around data access.
Thanks so much. I'm going to turn it over to Mark Meisner from the National Academies for a couple of audience questions.
Thanks, Asaf. I thought I would start with one about equity. Question is, would someone on the panel or the committee please address the topic of digital equity? It's in the report, but so far the discussion has mostly been focused on clinicians, vendors, systems, and policy.
So maybe I can start with this, and actually equity was an extremely important part of the entire report. I would actually say that as we thought about each of the different sections of the implementing high quality primary care, I think all of us were starting with an equity lens and thinking about that right up front. And, in the digital health chapter, we do talk about and address equity directly. I mentioned a digital divide. We know that this exists. We know that access to digital health and to systems is differential. We know that this divides along socioeconomic lines. It divides along cultural lines. and health literacy lines that divide along rurality lines. So there's so many factors that actually contribute to this. At the same time, digital health actually has the potential to improve equity. So it can make access easier. It can make understanding and action easy. So we made a real call to a couple of levels. One about thinking about equity in design. So we need systems that can be used by everyone, and especially our marginalized and underserved populations. It needs to fit with people's lives and their abilities. It won't be a solution for everyone and everything, and we know that. Some of the issues relate to healthcare design and how we use and implement digital health. Some of it relates to design and content and how it's put together and how it's accessed and used. Some of it relates to structural issues. We need to ensure that people have broadband access. And so telehealth was great during the pandemic if you could access it, but we have lots of people that can't. And I know I'm doing studies in our area that are having people use the web, and we're finding we have lots of patients that don't have phones, don't have an email account. And this gets to be real challenges. So there's a lot of problems that we need to address that span design, healthcare delivery, workflow, but also address some of these basic social factors that we need to be thinking about as a society to try and help folks as well. But equity is an important area to be thinking about.
Other panelists?
This is Andy. I was really impressed that as part of the funding, the big funding efforts, it was recognized that the FCC needed some money to try and deal with in particular, the rural bandwidth and access issue. And that has so many potential dividends. I think the actual amount of funding was relatively modest compared to the need. But in some of the infrastructure discussions, the concept of the rural electrification initiatives of the 1940s may well be matched with making sure that everybody in the country has digital access, broadband access. That won't solve some of the equity issues, but it is a step in the right direction. As Alex just said, that's one of the fundamentals. If you don't have that, you're going to have some difficulty. It also works to help clinicians who are practicing in isolated places to be able to reach out and get help from other folks as well, which is something that is one of the challenges if you go out and practice in a small community.
Thank you. Mark, do we have time for one more quick question?
Sure, I could do one more quick one. So this question says, many clinicians are using EHRs that may not be 20th century Cures Act compliant, and clinics cannot afford to change. How do we reduce the threshold energy needed to change? And how do we shift burden to EHR vendors for the functions of their products?
Big question to end on. Maybe one person take a quick shot at it. We'll let everyone have lunch.
Well, I've been making an argument. I think the data is one of the lever points. I think one of the key levers, and I think as data becomes more accessible, that can help to address some of that issue. I can also see a pathway, not to scare Andy too much, about even having some centralized, common systems that people can use and have access to that are low cost and build on that common data. So if we go back to one of the statements I made at the beginning, if we take a lens that digital health is a common good, just like primary care is, it really calls for making some national investments on that, which is not only about the data architecture, so systems that can be available for people who need these systems to care for their communities.
Any last 30-second comments from any of the panelists? Well, I think, please.
Alex, I just think Alex kind of combined his comments with equity. I mean, we're talking about a common good for all. We're talking about common digital health that we can share. And so I really appreciate you saying that. And equity is what we're after, and reaching as many people as possible and making wellness contagious. You know, being able to have access so that people can stay well, take care of their families, take care of their communities. And that should be for all of us.
Well, on that note of equitable, pragmatic wellness contagiousness, I wanted to appreciate the panelists here. I want to just, before we close, next week, the last webinar of our series is going to happen. It's on Tuesday, June 29th, 11 a.m. Eastern time, on accountability mechanisms for implementing high quality primary care. We are going to be joined by former Assistant Secretary for Planning and Evaluation at HHS, Richard Frank, as well as the former Secretary of the Senate, Sheila Burke, and former HHS Secretary, Kathleen Sebelius. It's going to be a great conversation and panel. Please join us then. And please join me in really thanking our panelists, Alex, Chris, Brenda Rice-Brennan, Andy Gettinger, Josh Mandel, and Sean Kavanaugh, really for a fantastic panel. Thank you for your amazing questions. I'm sorry we didn't get to answer all of them, but I really appreciate the time together and wish you a wonderful day, and thank you again.